Hello and welcome and thank you for joining this conversation with Dr. Quarraisha Abdool Karim, Associate Scientific Director of the Center for the AIDS Program of Research in South Africa, Professor in Clinical Epidemiology at Columbia University in New York, and Pro-Vice Chancellor for African Health at the University of KwaZulu-Natal. This is the second in a series of web-based dialogues we'll be hosting with leaders in global health titled Friends Health Chats. I'll ask a few questions of Dr. Karim to start us off, and then we'll be taking questions from the audience. Please type your question at any time in the Q&A box, and we'll get to as many of those as we can. Dr. Karim is one of the world's leading AIDS researchers and a cherished member of the AIDS community, and a personal hero to me. She's an infectious disease epidemiologist whose main research focus includes understanding the evolving HIV epidemic in South Africa, factors influencing HIV infection in adolescent girls, and strategies to introduce antiretroviral therapy in resource-constrained settings. Dr. Karim was the principal investigator of the landmark Caprisa 004 tenofovir gel trial, which provided proof of concept for microbicides, highlighted by Science as one of the top 10 scientific breakthroughs in 2010. She is currently a member of the PEPFAR Scientific Advisory Board and is co-chair of the UNAIDS Advisory Group to the UNAIDS Executive Director. Quarraisha, it's wonderful to see you, and thank you for giving us some of your time.
It's an absolute pleasure, Chris, and an honor to be here. Thanks for creating this opportunity. And it's really my pleasure to be joining you this afternoon with everybody else who's watching.
Wonderful. Well, first off, let me ask, what got you interested in research as a young woman? And did being a woman present hurdles for you in pursuing a scientific career? And if so, how did you and do you overcome those obstacles?
So that's a lot of questions there, but let me start by saying that I think most kids are born innately curious. And I probably got like a triple or quadruple dose of this when I was young. And fortunately, I had parents who, even though they didn't finish high school and were blue-collar workers, in fact, gardeners, they encouraged my curiosity. And at a very early age, I was able to go to school, and I had very supportive teachers who always encouraged me to do more and created opportunities to do that. So I would say all in all, I think it was the family setting, the supportive parents, the supportive educational environment. Even though I wasn't going to a fancy school, it was a state-aided school, that these dedicated, passionate, committed teachers played a big role. And I should say, at no point growing up did I ever feel, oh, as a girl, you shouldn't be doing this, or as a woman, you shouldn't do that. And maybe my passion and curiosity was so infectious that it go as I've moved along, and I've been a scientist now for nearly 40 years. It's a long time. And all of my experiences, whether it was my supervisors, whether it's my mentors, have been positive. But I can say one of the things that I know young women and women scientists have challenges with is just juggling the multitude of choices and things they have to do, and whether they have a family or not, and how do they juggle their career with family time, and those kinds of things. And I've been quite fortunate that my life partner is also my lifetime collaborator in HIV/AIDS, and we've been doing a pretty good job of balancing parenting roles. And at different points, as we've had to take on leadership roles, we've been able to support each other. But I do understand and appreciate and try to especially for encouraging more women scientists and trying to support them. In Caprisa is like a 85% women-led organization. So we're very sensitive to what the needs are and try and ensure that we create a supportive environment to encourage women to not only pursue science, but take on leadership roles in science as well.
Wonderful. In July, you co-authored an article in the journal Science about South Africa's lockdown in response to COVID-19 and the unintended negative consequences on prevention and treatment of TB and HIV. It's a few months later. What are you seeing now in terms of the impacts of COVID-19 directly and on other disease responses in South Africa?
Yeah, so it has been quite an incredible 6 months to 8 months that most of us have experienced. And I don't think anything prepared us for it. And going back to around March, April, when we first started to see the COVID-19 cases in South Africa, it was shortly after the visuals we were seeing in New York City, in parts of Europe, etc. And I think it was the concern of the number of hospital admissions and deaths that really got many African leaders' attention. And so our early response was about slowing down the spread of the virus and buying some time to prepare our health facilities to respond to the epidemic. And in that time, what happened was things were moving at a very, very fast pace. And while our initial COVID-19 response tapped into the HIV-TB infrastructure, there were two outcomes from that. Was when we were thinking about essential services, it took some of us, many of us who were playing a very big role both in responding and advising at that stage, to appreciate that, hey, there's multiple epidemics going on in parallel. So why, these services, these are the implications. And that was fed back very quickly to government, and those essential services started to be provided again. But there was a flip to that, in that the population and patients, for example, were reluctant to use health facilities. They were starting to see the health facilities as places that were full of COVID-19 patients, and they were scared to go to those facilities and acquire COVID. And so we have this, balancing act to do of trying to understand. And I think one thing that we've done in preparation for the lockdowns that were anticipated, or stay-at-home type policies, was multi-drug dispensing for AIDS patients. Mm-hmm. And I think that helped a lot, not just for AIDS patients, but also for people with other chronic conditions. So right now what's going on is that most of our facilities are back to whatever the pre-March normal is. So you can go to health facilities, you can access whatever services you need, and that's slowly picking up, because we had quite an extensive lockdown in South Africa. But I think we're starting to see some kind of normalization coming. Mm-hmm. Whatever normalize, let's just say pre-COVID type access to services being reinstated.
Yeah. In that same article, you also wrote that the COVID-19 response provides potential opportunities to enhance TB and HIV control going forward. What do you see as those opportunities now? How are you feeling about how, this response can lead to something better in the long run?
So I think maybe I can highlight 4 or 5 things. The one is the importance of science in the response. And there's a lot of lessons from HIV and TB, but HIV in particular, and scientific evidence. And we have seen, when you generate new knowledge, how we can transform a particular threat. In HIV, it was antiretroviral drugs and having triple therapy. Suddenly, a chronic, inevitably fatal condition became one that's chronic and manageable. There were struggles in terms of adoption of that as policy in many parts of Africa and outside of it. But with COVID-19, I think what we saw was strong political willingness to appreciate the science, even though it was incomplete and imperfect. The other part I thought that's really important is, once you know what the causative organism is, you need to do testing. And this is where the viral load platforms that were set up as part of our HIV response, we're able to tap into that. And very quickly, as the PCR diagnostics for SARS-CoV-2 became available, we're able to utilize that and institute testing at hospitals, in communities, etc. The third point I think that's worth flagging is the issue of importance of community partnerships and ownership. And we saw that. We saw how activism pushed the science and how activism and science together brought us institutions like the Global Fund, like PEPFAR, build solidarity, not just within countries, but globally, enabling in an unprecedented way access to same treatment to everybody with a common disease. And in South Africa, for example, we have a huge community health infrastructure that's assisted in delivery of services and being the buffer in terms of ongoing support. And we're able to tap into that infrastructure to do active case finding for COVID-19. And that's amazing, because that's the same infrastructure that we use for TB, for contact tracing. And so because that was there, so imagine like in March, you're starting to see community spread of SARS-CoV-2. You need to respond, and you need to hire something like 60 to 80,000 people. What would it take to do that type of hiring, that magnitude, and to have people hit the ground running? And we're able to do that transition within days because of that infrastructure being in place. So I could go on, but I think it gives you a bit of flavor of how important this was to build that rapid response within South Africa, and I think in many African countries. And perhaps just to underscore that it is the PEPFAR investments, it is the Global Fund investments, and it is the government investments that enabled us to do this with rapidity. So what it teaches us is good investments in public health, good investments in epidemics, whatever the form and shape it takes, better prepares us. And we can be sure that as we move forward in the 21st century, we're going to be facing many more pandemics, many more epidemics. And so Africa, I think, shines in terms of a great example of how when you invest in epidemics, it bears fruits and returns way beyond that initial and focused investments.
That's really interesting. I want to dig down a little bit on that because it's a really important point. How, as governments and donors are investing in particular disease platforms like PEPFAR, Global Fund, what makes those investments things that can have broader impact for health systems generally and be flexible and responsive when something new comes up like COVID-19? But how do you manage the disease responses in a way that you're setting a bigger foundation?
Yeah, I think we have to think about health and wellness in a much broader context. And I think that, people say healthy nations are wealthy nations. And while it may sound, a bit like Connie, the truth is that where you have poor health actually reflects a whole lot of structural issues that fuel ill health in terms of who gets sick, who's most vulnerable, and their ability to cope with that. So I think, if we take the HIV example and ARV treatment provision as one part of the HIV response, I think that the Global Fund and PEPFAR really came in working alongside governments and investing in prioritizing saving lives. And, when you think back to 2000, when you think back to 2003, 2004, I still have vivid memories of driving in Uganda between the airport and the city, and all you saw was coffin makers. And these days you do that same route, so death was all over. And death because we couldn't afford antiretrovirals. So the fact that these investments came in ensured equity in terms of access to life-saving drugs. Those life-saving drugs needed to be administered in health facilities, initially at least. And, when the patients were really sick, they CD4 count, and then you needed the diagnostic platforms. So in providing the resources for that, it helped in strengthening local healthcare delivery systems. And I think that while to some extent it also set up models for local governments, for national governments to see how investments in health pays back. And so that's one piece. And I think in COVID-19, we're seeing that again, that even though it's not the HIV, TB money that's going into the COVID response, the infrastructure, the staff who have the training and capacity. So it's the financial bits, it's the human resources bits. But I think also what has been highlighted in COVID-19, particularly for Africa and low middle income countries, is how national investments in science, technology, and innovation is so critically important. So, for example, here we are. We have the platforms to do the diagnostic testing, and we built the capacity to do something like 50,000 tests a day. And then what happened was we found we had a shortage of swabs. We had a shortage of reagents. We had a shortage of PPE. We had a shortage of kits because the whole world is clamoring for that same small pool. And so that's been an important piece, I think, going forward. The second for me is, as we think about vaccines and vaccine development, is there's, in a way, it's become run by monopolies. So some 20 years ago, there were multiple countries that could produce vaccines. And then they lost their competitive edge because you had subsidized production in this country and not in another country. And so production of vaccines that existed disappeared. And we're seeing that now when we got warp speed for therapeutic for COVID and also vaccines. The key challenge is going to be, can we produce enough so that we can also have equity in the distribution of it? And then we don't have this situation I just described on PPEs and diagnostics where those who have will continue to have access and those who don't. So those, we could talk a bit more, but let me pause there.
Yeah. Many people who will see this interview are in the United States or in other donor countries. What's your thought about how donors, what can donors do to help alleviate the negative impacts of COVID-19 directly and its impact on other disease responses, including HIV and TB, for example, through the Global Fund or PEPFAR or other programs? What's the donor role right now?
So that's a tough question, Chris, because I think that globally, all of our economies have taken such a hit. And we haven't quite felt the impact of the economic impact of COVID-19, even as we're dealing with the issues of illness and death and survival. So I think it becomes even more important that as donors, we don't shift focus from investments we've already made in HIV and TB. Now is not the time to reverse the gains that we've made. In fact, in HIV, we know that there are 1.7 million new infections taking place. And that's way off the 500,000 target that we set for 2020. We know that we still have something like 12 million people to be initiated on treatment. So we have to sustain the successes we have in PMTCD, in treatment provision, but also enhance our responses, because we've reached a critical point in terms of the convergence of knowledge and all those investments we've made in generating new technologies, in translating that new knowledge to programs and access needs to be sustained. And as we think about COVID-19, we can think about it as opportunities where investments we make in COVID-19, one, can draw on the lessons that we have from HIV, TB, and fast track our responses, but two, that it does provide opportunities for us to integrate our responses in a more coherent fashion. And that there are lots of synergies that are possible. And so let's not create more vertical things about this epidemic and this pandemic and that pandemic, that I think they all occur in the same vulnerable populations, and a reminder that we as a global community are equally vulnerable, whether we may have a high burden at this point or not, that as we work together in solidarity, as we have with PEPFAR, as we have with Global Fund, I think we've already set a precedent in terms of how we can change the world. And I think with COVID, we need to continue that, not now choose between things. And I'd like to make one last point, which is that globally, the non-communicable disease burden has been growing. And COVID-19 has flagged the importance of responding to non-communicable diseases. So for the first time, we have an opportunity in dealing with a multitude of infectious diseases and simultaneously dealing with non-communicable diseases. So our approach in communities, in populations, and in health facilities suddenly opens for, again, looking at people as a whole that are vulnerable to multiple things, not just a single disease or entity.
Right. Well, let's talk for a minute about how HIV is affecting adolescent girls and young women in South Africa and on the continent. You know, this population is among the hardest hit in the HIV epidemic in sub-Saharan Africa. Young women are 4 to 6 times more likely to be living with HIV than their male counterparts there. What are we learning thus far about approaches that can work to meet the multiple and interconnected needs of young women as they relate to HIV prevention and treatment?
So that's an excellent question, and I think it touches on a very fundamental issue of gender inequity. And we had some form of it in the Millennium Development Goals in MDG 5, where we're looking at maternal mortality. In COVID-19, we've seen multiple ways in which women, and particularly young women, have borne a disproportionate brunt again. And, you know, some of it relates to gender-based violence, some of it relates to sexual reproductive health, but some of it is so fundamentally about women who dominate as first responders in terms of healthcare delivery, but also in the manufacturing and retail sectors, where, you know, if you go in our supermarkets, in food production spaces, you're seeing more women there than men. And these were also places where first exposure of the virus took place, and then you saw some bridging and prior to the widespread community spread of SARS-CoV-2. So for now, that early bit of women being first responders, it highlights, I think, how important women are in society. And it is sad in the 21st century that we still have to be talking about gender inequities. And I hope that COVID-19 provides an opportunity for us to do more than talk, but to actually translate our actions in a way that is substantively going to address inequity issues and power differentials, and build on other movements that are there that contribute to vulnerable populations, which is also along racial lines and ethnic lines and so on. And I think the time is right globally for taking that agenda on. In HIV, we started to touch on this quite late, I would say 2 decades into the epidemic, even though we had good data. And I know that from publishing papers in 1990 showing that young women in in Southern Africa, and of course now we know that it's a key feature of the Southern African epidemic, as you just described. Women acquire infection 5 to 7 years earlier than men. And those alterations in trajectories of women and men stay for life. And when you take a society and half your population is decimated before age 25, you have to stop and think a lot more seriously about what you're doing and beyond today for tomorrow. There's a lot through the DREAMS project, particularly where we have been putting long-standing development issues on the table. So yes, the evidence may vary in terms of strength about what works or not. But the thing we've learned over the years is keeping girls in school, having them finish high school, not only benefit their life trajectories, but also benefit societies. And I think DREAMS has been doing a great job about that. But I think one of the gaps that we continue to face is the gender power disparities. And so when in sub-Saharan Africa, where you've got this age-sex difference, men are infecting young girls under 25. So when you're looking at men 25 to 35, is not when you start thinking about how do you change gender norms. And I feel that's an important gap as we work with adolescent girls and young women. How do we work with young boys simultaneously, so that they get a better understanding of what identity means, what masculinity means, what femininity means, what their rights are, what their responsibilities are? Then I think we start getting better to bridging those gaps, and we start to change those differences. And so I think some of the continued investment from Global Fund, from PEPFAR and governments generally, donor agencies, in continuing that will also have multiple returns beyond HIV and AIDS, but to creating better societies all around.
Hmm. You've been a pioneer in research on female-controlled HIV prevention. Can you tell us a little bit about the status of women-centered biomedical HIV prevention? And what do you hope the next few years will hold in terms of research advances in that area and also broader delivery of those kinds of interventions?
So the landscape, at least in the research front, is looking a lot more positive. And I think our initial work of proof of concept and development of PrEP, the WHO guidelines, has led to many countries adopting oral PrEP, particularly the daily forms of tenofovir and emtricitabine as prevention technologies, as part of expanded prevention technologies, and have been trying to move that along. But I think what we've learned with oral PrEP, both in men and women, that adherence is a challenge. And so once the proof of concept was established, the field opened up. And so we shouldn't really be talking about men when we talk PrEP. So there's the antiretroviral space where there's a lot of trials now underway looking at technologies that are less user dependent. So we've got everything from rings, to vaginal rings, to 2-monthly injections. We even got 6-monthly injections coming along, implants. In fact, the PrEP landscape is looking a lot like the contraceptive landscape, the female contraceptive landscape, where you've got a lot of options. And what we know is when you have options, you're more likely to find the right match for what you need at different points in your life. So, we don't stop with a single thing. If you have cardiovascular disease, we keep improving on that. And that's what we're doing with PrEP. And so new ARVs tested, new, less user-dependent technologies that may also be more health systems dependent. But if you can give an implant for a year, or you can give a 6-monthly injection, these are things that could be game changers. And that's what we can anticipate as we move along. that's telling. I would want to raise two issues, though. And the first is that there's also in PrEP the biological space where we're looking at broadly neutralizing antibodies. And BNABs are important for two reasons. One is that they prevent potential prevention technologies of their own. That's a biological, so you don't want to use a chemical. The second is that depending, and it's likely to be combinations of broadly neutralizing antibodies, very much like the combination of antiretrovirals in treatment. That's going to be the kind of thing that we'll move forward with. It also gives us better insights for vaccine development, which is important, has to be there, like the cure agenda, but it's been a real struggle. So I think that's what's promising about BNABs. But the piece, I think, for me, that's been increasingly disappointing is, for example, Gilead did the Discovery study, no data on women. And, kudos to the FDA for holding them accountable to say, give us the data on women. Because we continue to see advances in men, not in women, not in adolescent girls and young women, not in pregnant women. So, cis women, transgendered women. So we got to address all of the populations, and let me not also forget injecting drug users or substance users. So, there's a whole spectrum of people who need these PrEP technologies, and we need to just make sure we do that quicker and not wait and do the one and then stagger it and be dealing with data gaps. So hopefully the FDA pronouncement on the Discovery trial sets the trend where all people developing products simultaneously develop it for all populations who could benefit from that technology. So very exciting, lots there, but also lots to go before we can translate some of that exciting research to policy and programming. But it's a lot better than it was in 2010 or 2015 for that matter.
Well, I'll ask you one more question, and then we'll go to questions from people who are watching. And remember, you can ask questions in the Q&A box, and we'll get to as many as we can. So you've talked a little bit about this, but I wanted to drill down a bit. I mean, COVID-19 is hopefully teaching the world about the need for strong systems for health. And at the same time, we don't want to lose ambition for making progress against the major infectious disease killers like HIV and TB and malaria. So what's your perspective about how more vertical disease-specific programs and the movement for stronger health systems can work together in the future? How can HIV-specific programs help advance stronger and better prepared systems for health without losing the progress on HIV?
So I think, firstly, I don't look at things vertically because they very rarely occur in isolation. So, just take an example of a woman who is HIV infected. She doesn't just have HIV, she could have TB, and she could also have sexual reproductive health needs. I mean, we didn't put on ARVs and have her living just to breathe, but to live life, and part of living life would be relationships and so on. So I think immediately with HIV and just that example, you can see how things are interconnected. And we can't do it like a supermarket where you go down this aisle for your cereal and another aisle for your bread and another aisle for frozen foods or something like that, that we, as human beings, one entity. And also, when we're utilizing services, we don't have the luxury of spending large amounts of time to be, on this day, I'm going to get that service. On another day, I'm going to get another service. We'll be spending all of our life in health facilities just accessing services. So systems and integrated systems are critically important. I think in HIV, what we've also learned is that, initially when we provide services, we make it very dependent on providers. And then we find as the numbers go up, as we deal with pandemics, numbers are large or epidemics, then you find actually we can't cope with this. And I think in HIV, we've seen a lot of innovation as the numbers of people being initiated on treatment increase. For example, multi-month drug dispensing, one example, and not coming to the health facility every month. But, the importance, I think, what we've seen in the systems approach is of user empowerment. And the more empowered the user is, the more we can work more efficiently within a system and increase efficiencies and so on. But I think even as we think about a systems approach, I don't want to lose sight of the fact that some of the gaps that we have in responding to HIV comes from who we are leaving behind. So if we take too much of a health systems approach, that the individuals who are most vulnerable, adolescent girls and young women, men who have sex with men, injecting drug users, sex workers, we know who the populations are and can complete the list. They don't typically utilize the services for good reason. The services are not receptive for them. They're not designed for them. They're not welcoming. And so what we've seen is where you have peer-led service delivery and peer-crafted and designed, you have more effectiveness. And I think when we're thinking systems and we're thinking about integration, we shouldn't lose sight of some of the structural drivers that underpin why some people get infected and not others, and why we have to address some of those inequities that drive vulnerability at the same time. And so that's what I would say. And I think that PEPFAR, for example, and Global Fund has started to pay more attention to more like community monitoring, community ownership, community accountability, and so on, and how do we facilitate and bridge some of these gaps. So we know with any epidemic, with any disease, a certain proportion of the population will come to a healthcare delivery system, but we have to think more creatively. And I think the other last point I would like to make around systems is how much more dependent we are on the internet and data. And COVID certainly has flagged that for us. But then we have to look at, well, how is that data being collected, and how do we expand those basic surveillance systems? But also how much of this can be done electronically, and how do we use geospatial maps? How do we use data that we have that can be expanded so that some of the data in context can be used for smarter, more effective and efficient responses.
Great. Okay. Well, let's get a few questions from viewers, and this comes from Tamar. Can you elaborate on community partnerships, how government collaborates and empowers the community representatives who assist with contact tracing and other services? Did they report back to health services? So a little bit more about community partnerships and their value and how they're working.
So it's a good segue from the last point around that, you can't provide, it's like such a top-down approach. I know what the users want and what to do. And I think in Africa, one of the reasons we have this incredible numbers that have been initiated on treatment is because we've had community partnerships. And some of those community partnerships are with, for example, community health workers. But we also saw with ARVs very early on in treatment prevention how important treatment literacy was, and how users and, in fact, infected persons who were part of accessing services were actually the best educators. Now, having said that, we can't have a situation where people are key to healthcare delivery but are not recognized in any way, are not paid, and not rewarded in different ways. So there's bits that we all do altruistically, but there's also a bit of fairness in there. So in South Africa, for example, we have community health workers that are a formal part of healthcare delivery, and they use the primary healthcare clinic. So because we have like a tiered system of healthcare delivery, and it's largely indigent populations using, if you have private insurance, you can go and get access in private hospitals, but the bulk of healthcare delivery across Africa is in the public sector. And so you have these primary healthcare clinics. That's your first port of call in interaction with a professional healthcare provider. But who's the bridge between community and the healthcare delivery system? is your community health worker. So you can see how important it is for staff at a primary healthcare facility to have good relationships with the community health workers, who are usually volunteers and who, of their own bat, care about people around them and voluntarily do a whole lot of things. But that's been formalized, and they get a lot of training and this accountability of coming both to the community who they serve, but also to health face interfaces that they interact with.
Mm-hmm. Great. So this is a question from Gemma. Are there ways that COVID-19 presents potential opportunities to enhance HIV and TB services for adolescent girls and young women in particular? Getting PrEP to this group, is virtual online outreach or HIV prevention being done? Are there other approaches we should know about? So ways, it's kind of back to something you've covered to some degree, but what are the opportunities here? Or what do we need to take out of this tragedy of COVID, particularly for young women and girls?
So I think there are a few things we can certainly tap into, and I'll just use PrEP as an example. So, we've done demonstration projects prior to policy and programmatic rollout, and what we found is that young women don't come to health facilities to access PrEP, but if you take the service to the community, they're actually able to reach both men and women. So the men came, and suddenly men also wanted access. In fact, 40% of who we provide PrEP to in the community is men. So I think that's the bit around gender inequities and understanding and taking responsibility, because most of the the people who use services are typically women coming to health services, and so taking services to the community is one way. I think also the issue of schooling is so important. And I've seen, having done programs in schools, and this is something I want to also put on, is we know comprehensive sexuality education is important, but we've also seen how policies and foreign policies influence whether schools deliver comprehensive sexuality education or not. And it's both donors, but also NGOs from foreign countries impacting and influencing the ability and decisions to roll out comprehensive sexuality education. But we know knowledge and education and information is only a first step. We need services. So I think if we take services to schools and provide it, and some places it's a standard thing, a school, you have a school nurse and you have access to services. In Africa, that's not a standard thing. And so taking the services to the schools, I think does two things. It builds on the education. More education, we find fewer teen pregnancies, we have fewer unplanned things, and lower HIV infection rates and all that. So that school is a very important environment where we can build on the HIV Dreams project, for example, keep girls in schools, empower them, let them finish their schooling, and let them graduate high school and to a point where they have the cognitive maturation make rational decisions. So I would just give those two as examples of how do we take things into the community and reach populations where they can be reached? How do we tap more into the peer support network? Because when young people are their own voice and they shape and determine their own agenda, those are much more effective. And how do we use schools as greater opportunities?
Great. We're almost at time, but I can't resist one last question, and this comes from Prakash. In the context of disruption of procurement and supply chain due to COVID-19, how can we promote multi-month dispensing of ARVs, particularly in resource-poor settings?
Yeah, that's an excellent question, and I kind of touched on this very early on when I was talking about the investments local governments and national governments need to make, so that we're not all dependent on monopolies for production. So the multi-month dispensing helped the gap when we had the, overnight lockdown and how you're going to get access to medication and so on. But we're also fast reaching the point where that 6-month dispensing is reaching the end. And so what's going to happen beyond that? And this is where I think the supply chain issues start to come in. And I would add some of the infrastructure that has already been built for electronic data capturing and monitoring. Because if you can put that in there, you can project and predict where your needs are going to be, and ensuring that the delivery is happening. So one of the big issues with production and access right now is not in the multi-month dispensing as we go forward, but in getting supplies to the country. And with the restrictions in international travel, that's become a big challenge. So I think in countries where they do their own production of everything, PPE, reagents, kits, and drugs, I think it also raises issues of intellectual property. In HIV, we've managed that, but not in other diseases. And COVID highlights why it needs to extend to COVID. And we're starting to see how Unit 8 is coming, and new platforms that draw on that HIV experience and so on. But I have no doubt, because a lot of production capacity and manufacturing capacity has been diverted to HIV, to COVID-19, and that we're going to have these shortfalls. So I think we have to start thinking very fast and responding very fast to make sure that we don't have any breaks in continuity of medication, etc.
Right.
So systems investment, local investments, and let's get a better map of where the challenges are and try and fill those. And this is where the digital technology is a big plus.
Excellent. Well, Dr. Karim, I'm so appreciative of your time and the wonderful comments, and very, very helpful to us, very thoughtful. Thank you for your leadership over the decades and for decades more. So thank you for your time, and thanks to everybody for joining us today.
Thanks very much, Chris, and for the opportunity, and also for our long friendship that spans several decades, as with others. And I think that's so important as we tackle challenges that lie ahead. It's the solidarity, it's the friendships that give us resilience to keep moving forward. Thank you very much. Goodbye.
Thanks, everyone.